Welcome to this second in our mini-series of interviews, covering different perspectives on clinical functional MRI. In this episode, I speak to Dr. Laura Mancini. Laura is a clinical scientist, and more specifically an MR physicist. She works at the National Hospital for Neurology and Neurosurgery, which is part of the UCLH NHS Foundation Trust in London. Hi, Laura. Thank you so much for joining me today. I was wondering if you might just want to say a few words first about your role as an MR physicist at Queen Square, and also kind of what brought you to MR physics as a career.
Yes, hi Vicky. Thank you for inviting me for this interview. And yes, so I started as a clinical scientist at Queen Square in 2004, and I was employed exactly to implement fMRI service in the clinics. And we started from being a time-limited project. So I had a temporary contract for a couple of years, and then because the service took over and I was very successful, it was extended. And yeah, so what I did my degree in physics in Rome, and I already started doing some MRI on trying to understand how the brain works, and so that's what really got me interested. And then I did a PhD in London on applying MRI technique to tumors, and then
Okay.
yeah.
Nice. So how many of you as physicists are supporting the fMRI at Queen Square?
So at Queen Square, we are 4 physicists at the moment that support this type of technique, and of the 4, so all 4 can help with the acquisition, and currently 2 help with the analysis, and the other 2 are being trained to be able to do that.
Okay, so it's quite a big team. How many patients are you scanning? Are there quite a few regular slots that you do?
Yeah, the slots are quite variable. Overall, in 1 year, it ends up like 2 per week. But there are weeks in which we've got more patients, and weeks in which we don't have many patients.
Okay. And who else? What other types of roles do you have within your team that are involved in the fMRI?
So we do also the tractography for this type of patients, and then the physicists are involved with spectroscopy, MR safety, and so all other roles that are not necessarily strictly related to fMRI, but then by the department.
So do you have, when you're doing the fMRIs, do you have others like neuropsychologists or radiologists that are taking a sort of active role along with yourselves?
So yeah, a lot of the patients have a neuropsychology assessment before and after surgeries, but we don't interact with them for the fMRI. For the acquisition is generally physicists and radiographers. And then what happens is that the physicists would do the analysis of the data, and then we would meet with the neuroradiologist, and the radiologist will do the report.
Okay.
And, yeah.
So what sort of setup do you have for doing your fMRI acquisition?
So we have MRI compatible monitor inside the room, and then we have a box that receives the trigger from the technical room and converts it into trigger for the computer, and using a free software for the paradigm presentation. So we have it's not all from the same company. We have bought different pieces from different companies.
Yeah, it evolves, I guess, over time, piecing
Yeah,
things together.
it started with not having anything, just going through the intercom, go and stop.
Okay, nice.
And it evolved over time, yes.
So in terms of the patients you see, obviously every person is different, and I guess ideally you kind of adapt to individual patients according to their differences or conditions or symptoms. What sort of information do you try to gather about the patient before the scan, and also when they arrive? What sort of questions are you asking to try and make sure you've got the most suitable protocol?
Yes, so the main information that we try to gather beforehand is if it is for fMRI language, what language do they speak? Because we got patients coming from all over the world, really, from Arabic countries to European countries. So we want to make sure that we've got the language in the correct language. And then we try to see if they have a specific deficits. But we tend, we tend not to have that much of information before they arrive. So then when they arrive, we mainly do our fMRI on patients with brain tumors. In the trust, there are also patients with epilepsy cases, but they are seen at a specific unit in Chalfont, and so
Okay.
they have the special day fMRI usually in Chalfont. So it's mainly tumors, and I think our referral process is a bit is mostly on patients that have lower grade tumors, because there are the cases in which the surgeons are worried that they might damage more their language, their activation. So they tend to be patients that don't present very big deficit. Usually when you talk to them, you wouldn't even realize that they have a problem. So the vast majority of our patient is like that. There are some cases in which at higher grades, or they come with, for example, that they cannot move a hand, and so in that, if that happens, we try to change our task to a task that the patient can actually do.
Yeah.
So a lot is the assessment during the day. When they arrive when they arrive, the radiographer would do the safety check, and then the physicist would speak with them to explain the task. And in that conversation, then you try to understand if the patient is understanding, or you try to ask them to repeat some of the tasks that you showed. You reassure them that you will remind them at the beginning of every scan what task they need to do. So,
So when you are preparing them for the task, do you show them the specific task, or do you just sort of explain the general impression of what they'll see and ask them to give some responses just to make sure they understand?
So we have laminated pages with the instructions that they will actually see. And often we show them these slides, these pages, just to make sure that they understand. But sometimes we just explain and ask them and we give them some examples and see if they are happy with that.
Okay, nice. So for you, obviously, you've had a lot of sort of 20 years of, I guess, building up your processing pipelines, and I understand that you guys have a pretty rigorous way of analyzing the data with lots of steps. I'm just wondering if you could maybe give a bit of a idea of what you think are the most important steps when it comes to pre-processing and analysis when it comes to BOLD for TMAPs.
Yeah. So for sure, the main task, the main step is the realignment of all the images, so that you remove the head motion artifact, and when you do that, you have a graph that shows you how the head moved during the task. And the main assessment is if that graph looks like there was a head motion that is correlated to the task. So the head motion really happens at the same time as the task is active and passive, then that is the only way that task needs to be repeated. That is not often in that case. The fMRI becomes not usable because it shows false positive and false negatives. So for that one, it's really important to have a way of assessing this head motion during the scan or immediately after the scan, because that's the only thing in which you really need to repeat the task. Then other steps, we like to put the motion parameter inside the GLM model.
Okay.
And I think that is quite useful, but I'm aware that a lot of the CMAT software don't allow to do that. I think for robust tasks like motor and so for robust block design task, it may be you may get away without introducing this motion parameter in the model.
Mhm.
But if you want to have more complex task, maybe you need to use you need to be able to introduce this. The another thing that is useful is having a B0 map that shows you the areas in which the fMRI is not reliable, so where the distortions are and or the signal drop is too big.
Mm.
And another, most of the software just show you those areas so you can understand where, in which area the fMRI is not reliable. And the software that we use, you can introduce that in the pre-processing so that it will correct for image distortion.
Nice. Okay.
So yeah, if that was available in the CMAT software, it would be fantastic. But it's quite I haven't found CMAT software that can do that. So I guess so these are all desirable. So the main the head motion correction is really a must.
Mhm.
The desirable are these being able to introduce to correct for the distortion and to be able to add um, the motion parameter in the design. It's very useful also to be able uh, to tell the software about the design in seconds rather than in volumes, because sometimes you may have a discrepancy between the the block duration and the number of volumes.
Yes.
So and actually from a statistical point of view, if they are different, it is better, is statistically more powerful, because basically you are so for example, in a block of 20 seconds, you may have 4 or 5 volumes.
Mm.
And if the two are synchronized, then you always sample the same point in the hemodynamic response function. While if they are not synchronized, you sample different points, and therefore your sampling is improved, your statistical outcome is improved. And so if I were to choose between software that allow to specify it in seconds or in volume, I would always prefer the one in seconds.
Have you done work to sort of show that it gives an improvement in your TMAPs?
Um, I know that there have been publications about it in 20 years ago, I think. So when I started. So I haven't done the work myself because it's a bit complex to do, because you need to do 2 separate acquisitions
Mm.
to show that. But when you repeat acquisition, also there is a variability even in the same person, because there is learning, and so
Yeah,
yeah.
it's very difficult to isolate the the difference is because of that reason, I guess.
Yeah, yeah,
Okay.
but I know that there have been publication in
Mm.
15, 20 years ago, yeah.
Okay. How important is quality control during the processing, different stages of processing the data for you?
It's really important. As I said, the main bit is seeing if the head motion correlates with the task. And also in patients with tumor, especially if they have carcinoma or if they have the type of lesion that can bleed, then bleeding would cause a hemosiderin deposit in the brain, and that would cause the signal from the API to disappear. So basically, in areas in which your basically API shows black areas, those are where, since you don't have signal, you can't see how the signal changes during the task. So if those area happens to be in the area that you are expecting to be activated, you will not see an activation, but the brain might be perfectly functioning underneath. So in patient, I would say that it's always important to look at the raw API and see if there are this type of artifact in the image, and where they are with respect to the anatomy, if they are with respect activation or not. Then I know that lesions like AVMs are a bit more difficult to interpret the results. They may be more difficult to interpret the results because basically in your fMRI you assume that there is a neurovascular coupling, and with the AVM that they change all the blood flow, and this neurovascular coupling may be compromised. And so I guess if you know that you are assessing AVM cases, maybe a bit, need to be a bit more careful of what is happening around that area.
Okay. So once you have your T-maps, what happens to the data, and sort of how do the surgeons use them? Do they just kind of view them and make some broad decisions, or do they actually go into the neuronavigation process?
So the maps, with the maps, then we produce some overlays that we send to the PAC system, and also some images with the colors. So I think they get used in different ways. So the PowerPoint that we show, in which we show selected images with the color and all the maps together, I think they are used to identify which patients would need to be operated awake and which asleep. And they can be used when the surgeon speaks with the patient to make them understand better what are the risk of the surgery, and so they can make a better informed decision on whether they want to have the surgery or not. And the overlays, I think they can help the surgeon deciding beforehand the approach that they will have to the surgery. And then I know that they also use them during navigation. So they do put them in the navigation system and create objects that they in surgery.
So that's then a sort of a starting point for the cortical stimulation.
Yes.
Okay. So obviously you have many years of experience building up the service there. What would you have any advice to potentially give to a site which is just starting up with a new service? They haven't done fMRI before. Maybe one person has brought some experience from another center, but they're trying to sort of build up a team. What's your advice from your own experience?
Yes. So I would say that when I started the service, it was the hospitals weren't using so much digital information. There was no Epic, and everything was paperless, So it was easier to introduce software and computer to trial things. Nowadays, with the medical device regulation and computer being used in the hospital and all sorts of things, the regulation have become much more complex. So it's quite there are there have been, I know that there are guidelines to understand what you need to do for a software, either if it is CE marked or non CE marked, but they're quite difficult to follow. So we have now we have an IPEM task and finish group in which with the aim of which is try to provide some guidance to for people that actually want to start this process. From a practical point of view, I would say that sometimes it's also difficult. So if you want an MRI compatible monitor inside the room, that is something like 25,000 pounds. And then if you want to have your CMAT software to do the analysis, would be a bit more expensive. So to convince your trust that you need that money might be a bit difficult to start with.
Okay.
If I don't know if the service is really going to take off. And so you may think of having some more simpler tasks. So start with a simple task like the motor task and see if you can do it on a volunteer with auditory commands or using some instructions through the windows in the control room. So in a way that you don't need the monitor inside. So start and see if it's actually used, and then you can provide a bit more well, you can have data to convince better the trust that you need that money for the service. For sure you need the key people. So if you don't have a clinical scientist, then you need to have a radiographer and a radiologist that they both have some training in fMRI. So there are all over the places training that takes place that can be online or various company provide some training or contact a team that you know they are already doing the fMRI and get some advice from them. I think everybody's happy to help each other with this. So also when you do the acquisition, is really important how you talk with the patient, how in that conversation you're trying to assess if they understand you, if they understand the task. So it needs to be, you need to be focused and dedicated to that scan. If you are in a center in which one radiographer starts the scan, another finishes, and stuff, it becomes a bit difficult. So for that, at least for that patient needs to be focused.
Yeah.
What
Okay.
you need to do. Yes, I think and when you start, so start with a simple task and do it on some volunteers so that you know if it's working.
Okay. So start with something, and then the more you give, probably the more they will ask for, and then you have a bit of a case.
Yes.
Forward. Okay. Well, thank you so much. Thanks for joining me. That was really informative, and I'm sure many people will benefit from your experience. Yeah, and I'll see you soon.
Thank you. See you soon.
Okay. If you enjoyed listening to this discussion, please do check out the other episodes in this series. Please do also head over to our website and sign up to our user forum. And please follow us on LinkedIn to hear of any future events.